like to introduce Dr. Ryan Meili. Ryan is a family doctor at Saskatoon's Community Clinic, West Side Clinic, that many of us visited yesterday. So we get a sense of where Ryan works and the population that he serves. He's also assistant professor in the Department of Community Health and Epidemiology at the College of Medicine at University of Saskatchewan, where he serves as the head of the Division of Social Accountability. And that's really one of the exciting things about Ryan. He is a physician who sees health as a political issue and is very committed to making those two things on people's agenda together. As such, he is here to launch Upstream, which is a very concrete way of combining politics and medicine to address what we know is where we need to go in health, which is addressing issues upstream. So you can read his bio. I'm not going to read it all out, but I'm very excited. I was able to introduce Ryan when he did his book launch in Halifax last year, and I'm thrilled that I'm here in this capacity to invite him up to the stage today. Thank you.
To thank you for allowing me to hitch the Upstream launch to this conference to connect this new organization to the important work that your organization is doing. I think there's a lot that we have in common, and I hope that this will provoke some discussion and hopefully in the long term some productive partnership. The image you see in front of you is just sort of a placemaker, but I kind of feel I have to confess that is my baby in the river. You can kind of see me underneath. I had to give a talk about public health, and so we used my son, who was then one, as an example of the baby in the river. I'm sure his therapist will enjoy the story. I'm very glad that many of you were able to visit Westside Community Clinic and the neighborhood yesterday, because unlike my talk yesterday to Health Promotion Ontario, when I had to actually convince people that there is an inner city in Saskatoon, Toronto people weren't quite sure that made any sense. You've actually seen the community that we work in. I live on Avenue F, and the Westside Community Clinic is on Avenue P, so just a little ways down the alphabet from one another. And it's a neighborhood with many charms. There are many things that I love about living in that neighborhood. I often say that it's so urban, it's rural. I'll be out raking leaves and somebody will lean over the hedge and say, "Hey doc, how you doing?" Or when I'm, excuse me, when I'm walking to work, or sometimes I think to Tim's chagrin, taking my longboard down the street to work, I hear a lot of "Hey Meili, hey doc" in the neighborhood, and that's pretty awesome. But it's also a neighborhood with many serious challenges. You may have already heard about the great disparities, thank you very much, in health outcomes between the west and east side of Saskatoon. Very large differences in rates of diabetes, hepatitis C, sexually transmitted illnesses, depression, multiple times the amount of heart disease, far worse rates of infant mortality and overall mortality. There's just a great divide in our city in terms of health outcomes. And that's not different from, I'm sure, many of the places that you work. We were hearing from someone yesterday talking about the Code Red project in Hamilton that showed the 20 years difference in life expectancy between the lower city of Hamilton and upper city. This is something we see all over the country. In Saskatoon, there are some particulars that are a little bit different. We've seen an explosion in HIV over the last few years. When I first started practicing at Westside Clinic, we had about 50 patients who were HIV positive. Now we have almost 400. So there's a lot of challenges in working with a community that is struggling so much that is happening, where we have triple the rate of incidence of HIV of any other city in the country. And it impacts how we practice. People's lives are very chaotic, and so our practice is somewhat chaotic. Dr. McIntyre refers us It says our patients deal with opportunistic infections, so we provide opportunistic care. Other people have described it as low threshold. So if somebody missed their appointment but comes in the afternoon, we still see them. If somebody has a 10-minute appointment but is in a real crisis, we see them for an hour. It's a constant challenge, but we find a way to do it. And there are great pleasures in that. We probably get told to F off more than any other doctors in the entire city. I think that's probably part of our experience. We also likely get hugged more often than most doctors in the city, and often by the same patient in the same day. Yeah, it definitely happens. And this work takes us places that we wouldn't otherwise go. It takes us into the lives, the homes, the stories of people that most of us wouldn't have a chance to meet with. And it's a great honor and often a pleasure. But it also often takes us places that we don't really want to go. Like a few weeks ago, when I went to a reserve north of Prince Albert for the funeral of a 25-year-old mother of 2. That's not the kind of place that anybody wants to be. Obviously, it was an honor to be part of the celebration of her life, but it was a great sadness to see her pass. This was someone that I'd become quite connected with, and she actually wanted me to share her story. She used to tell people, Meili tells people my story. She liked that. Because her story, I think, so illustrates the challenges we're facing. Call her Lisa, that's not her real name, but want to respect some degree of privacy. She had first come to me with chronic pain. She'd been hit by a car and had a pelvic fracture, and that was repaired. So she had some hardware. When I first examined her, she had a screw sticking out of the back of her hip about that far. So lots of pain. And I prescribed a pain medication for her, Dilaudid. And that is the appropriate medication for that kind of pain, according to my clinical judgment at that time. Talked to her about it a week later and said, so how are you doing pain-wise? Of course, at the same time, I was also getting her engaged with the orthopedic surgeon to try and get that repaired, not just handing pain meds and telling her to go away. But a week later, I said, how's that been working out for you? She said, well, okay, but it all went in my arm. And that puts a doctor in a very strange position, because you have somebody with very legitimate pain. They actually need the care you're providing. At the same time, they're using it in a way that's dangerous and harmful to them. So what do you do? What we did was work with the pharmacy next door. We have a very good relationship with the pharmacy next door, and they were doing daily release of a long-acting morphine so that we could avoid, she would just take that in the pharmacy, we could avoid the temptation to use the medication differently. At the same time, we worked to get to know her better, get her connected with help for her addictions, and try and get her life more stable so that we were able to organize a proper fix for the problem she had. Unfortunately, while we were getting to know her better, we got to know that she had hepatitis C and HIV, and that her CD4 count was actually quite low, under 200. She was starting to have repetitive pneumonias and other opportunistic infections. She was quite sick, and her life was one that was too chaotic to start HIV medications. She was using lots of cocaine. She just wasn't able to take a daily medication. She wasn't ready for that. But we continued to work with her, continued to see her regularly, and got to know her more and more. And then something a bit odd happened. Bad luck on bad luck on bad luck for Lisa. She was sort of a cat with 9 lives. We were amazed at how many things she could actually live through and manage to survive and stay hopeful. She wound up with a lymphoma. And a strange thing, a lymphoma that wasn't connected to her HIV. But that may have been, at least for a couple of years, the luckiest thing that happened for her. She got scared and got serious about getting better. We got her into hospital, worked with social work nurses, dentistry, the oncology team to get her the treatment, actually got her through her treatment of her lymphoma, got her through her chemotherapy. In fact, to the point that her HIV was under control, her CD4 count had climbed into the 700s, her cancer was completely cleared. There was no sign of any further lymphoma, and she was doing really well. In fact, I shared a bit of her story at the NDP leadership campaign in March as a good news story at that time, because she was excited. She'd bought a membership for the NDP, and she wanted to vote for me. Well, I assumed it was for me. She wanted to vote. I shouldn't make any rash guesses there, but she wanted to vote and participate, and she was really having hope. She wanted to study and get into doing some hairdressing work. So that was really exciting to me. And this is the part that's a bit mysterious. Over the following months, her condition continued to deteriorate, and we don't really know why, but she just kept losing weight, kept getting sicker. She ended up moving to Prince Albert, and she did pass away. It's now about 2 months ago that she died. And I just can't help but think that, no matter what we were able to do clinically, no matter what services we were able to mobilize, we just weren't able to overcome what went before we met her. And this is a very clinical story, and I tell it in a clinical way, partly because that's how I end up first understanding many people. That's how they introduce themselves to me, is with their clinical complaints. But of course, it's not a clinical story at all. It's a social story. It's a story of someone who grew up in poverty, whose education was cut short too quickly because they became a mom too soon. Someone who is part of a community that's been marginalized for generations and generations. Her parents and grandparents were in residential school, so her models of parenting, her experience in early childhood were very poor. And she struggled with being abused, and ultimately with substance abuse that I think, as so many of our patients do, because she was treating all of the things that had gone before in her life. But when we talk about people's stories, we often do focus on the clinical side of things, and we almost keep a firewall. There's a big disconnect between the clinical witnessing that we do and the political action, the social change that we work for, so that people don't wind up in those circumstances. And I don't think that's helpful. I don't think it's healthy. I think we need to be constantly keeping in mind, as we're working with patients, the larger picture. And I know that you know that. But I want to emphasize a little bit more about how we might be able to do that, because I believe the only way we can help Lisa is through social change. And the only way that social circumstances can change is through political will to increase equality, to increase the available supports, to make housing affordable, to deal with the social determinants of health, not just health care. So we'll move on to my first slide, which shows us how well we're doing at that. This is the Canadian Index of Wellbeing. It tracks the growth in GDP versus the growth in a variety of indicators of the health of our society, from health outcomes to education attainment to democratic engagement. And what you see there is very serious growth in terms of the GDP, and very modest growth, really, in terms of how much that economic growth is translating into better well-being. And there's a lot of, we could spend several conferences digging into why exactly that is. But one of the things that I'd like to talk about that contributes to that is bad frames. Our discussions about how we make political decisions are framed in ways that result in this outcome. Frames like austerity versus abundance. This idea that we just don't have enough to deal with the problems that we're witnessing. That doesn't really go with this slide, with the amount of economic growth that we've seen. We do have enough, but we've been told that there is no alternative, that we must cut down on our expectations. Or frames where we're really stuck in reactive mode, reacting to crisis after crisis, rather than thinking ahead, planning for what we really want, planning to achieve better well-being. So what I believe we need is a new frame. We need a different way of looking at things, a more inspiring frame, one that speaks to the best in us, that really promotes well-being. And I find it helpful for me when considering, well, what kind of a frame would actually do that? What would work? To back up and say, what is it we're trying to achieve as a society and government as that manifestation of our societal choices? What are we wanting to achieve? I would say it's two simple things. It's what's good for us, trying to improve our lives, and what we want. Actively being involved, having a choice in setting those priorities and identifying what we need and working towards that. And what I've been proposing is that health is a frame that meets those criteria at the very least, in that one, it's what's good for us. If you take the World Health Organization definition that you're all familiar with, far more than just the absence of infirmity, but full physical, social, and mental well-being. Wouldn't that be an amazing mission statement for a country? We're seeking to achieve full physical, social, and mental well-being. And it's also what we want. We talk about it all the time. Our language is full of references to healthy debates and healthy relationships and healthy appetites. I imagine there was some toasting to each other's health at some points during the conference. And that's really manifest as well in our political discussions. We talk all the time about healthcare. It's always at the top of the list in terms of the issues that people are most concerned about. Now, of course, health is far more than healthcare, but I think that's a good surrogate for the amount of interest that people have, the amount that people care about this. They may have other dreams. Health isn't everybody's goal. People want to be great physicians, leaders in community health centers. They want to be athletes. They want to read everything that Agatha Christie has ever written. People have many goals, spiritual goals, other goals, but health acts as sort of the highest common denominator. It's the prerequisite for the enjoyment of the rest of our lives. So it's not that, I don't think that health is something that distracts us, although there is often that criticism. Maybe we focus too much on healthcare and we don't focus enough on justice and education and all those other factors that make a real difference. And I think that's almost true. We focus too much on healthcare. We don't focus too much on health. We just focus on it wrong. We focus on the wrong parts of it. We're incomplete in our focus. And so we'll put up this list, which I know you're all very familiar with, but I think it's a good reminder just to step back and say, well, what does make a difference? What are the things that matter the most in terms of health outcomes? And as we see, our work, as important as it is, it's way down the list. Income, education, housing, et cetera, are far more impactful in terms of health outcomes. And I think this list is useful as a reminder. I also think it's useful as a guide, because you can think about this list and map it onto different ministries, different agencies within government that can have serious impact. These are the social determinants of health. They're things that our social policies can change. So it guides us to action, but it also serves as a means of, when we use health as our goal and use the determinants of health as guides to action to try and reach that goal, it gives us a means of measurement. Health is something we measure all the time in greater and greater sophistication of detail all the time. It can serve as the canary in the coal mine of the health of our democracy, of our society as a whole. I think that opens up a really exciting potential change, which is a move towards evidence-based policy. We've seen this shift in medicine, where we've gone from a time of apprenticeship, of best guesses, of what the science seemed to say, but really very much the individual doing their best decision, making their best decision to try and treat the patient, not necessarily having an in-depth understanding of what we focus on now, which is evidence-based medicine, the studies that are behind our choices, and a constant critique of the choices we're making, recognizing that we're having to advance in evidence all the time. Politics is still, and some parties more than others, I suppose, but in the pre-evidence, prehistoric, sometimes it would appear, but pre-evidence phase, people focused on ideology, focused on what polls the best, rather than what's been studied, in terms of understanding the depths of the challenges and the details of the challenges we face, looking at the best examples of what's been successful locally and in other places, implementing in partnership with the communities, and ultimately doing that reflection work and honestly reflecting back rather than saying from the government side, here's what we did and here's why it was wonderful, and the opposition reading the same data and saying here's what they did and why it was terrible, actually being honest about the types of evaluation we're doing. So what we find, however, and I think this is a frustration that hopefully is on the way to being alleviated, but it's a frustration certainly that I've felt, and maybe many of you have as well, is we know this list so well. We know it to the point that we're almost bored with it, because what happens as a result of knowing that that list is there? It exists among folks like you, among academics, but has it really made the leap into the common knowledge in order to influence action? And this is what Dr. Dennis Rayfield talks about, the phantom zone, that the social determinants of health exists within a, this is from Superman 2. And I thought I was really dating myself when I put up a slide from Superman 2, which is from the 80s. And Dr. Rayfield said in his New York accent, I was talking about the Superman comics from the 1950s. So I guess we were each dating ourselves. But this is the side, these are where the bad people went in Superman comics, and they were stuck in this eternal other dimensional phantom zone. And he describes social determinants of health as existing in something akin to this, where it's known, but doesn't make the, known among the people who know, but it doesn't make the leap. It doesn't get translated into the public discourse and thus ultimately sufficiently influence decisions. Now, I think there's been some change in that. And many of you will know Michael Marmot, who writes a lot on the determinants of health. I was lucky enough to have him participate in a book launch with me when the CMA was in Yellowknife last summer. And he gave me heck for even talking about this phantom zone thing. He said, I like your book, but this, you see where we were at the CMA. He was the keynote speaker at the CMA. Jenny Buckley put out a fantastic paper about the physician role in health equity at that meeting. There's movement, and he was saying, you know what, Ryan, we're leaving the phantom zone. And I hope he's right. I hope he's right. And I think there's some sign that that is happening. The work of the Ontario Association of Community Health Centres, the AOHC's work on trying to actually integrate the CIW into how they do work. There's been the work on this from the CMA. We've had more than 3 presidents now, 4 presidents now who have been focused on addressing the determinants of health rather than focused on moving towards more private care. So that's a fantastic shift. I sort of kept making somewhat snide remarks about how shocked I was that the CMA was becoming a radical left-wing organization, but the shock is wearing off. It's just starting to become who they are, and that's very, very encouraging. And I think we're also seeing more people trying to think about how, and I know Jenny heard this lots when she was doing her work on the physician role in health equity. So what does this mean in frontline care? So trying to think about how can you actually integrate these concepts into how you address the needs of your patients. This is an interesting book that came out just a couple of months ago. It's a TED book called The Upstream Doctors. And it's a little bit like what I'm talking about, but really focused on the role of physicians and other healthcare providers in integrating concepts of determinants of health into their actions. And this Dr. Manchanda, he talks about different things that have been done around housing projects, many of the sorts of work that CHCs around Canada have done to try and enhance the determinants of health action around in terms of response to the needs of their patients and clients. One of the things that a group of us has been working on, and I know this is connecting with some of the CHC work in Ontario that's underway already, is trying to develop a clinical tool where we'll actually assess the determinants of health in a clinical setting, but more importantly, have that clinical tool then move us towards an intervention tool. be assisted by collecting the resources that are available, using a software-driven tool to identify which resources really respond to the determinants of health that that patient is identifying, so that we actually have a sense that, oh, here's what I can do. My patient is struggling with the determinants of health. My only options are not medication. I can now access this service as well. And this is, I think, the sort of sneaky second half of a project like that, also identify opportunities for advocacy as we notice what isn't available, what we aren't able to deal with. So I think it's an emerging idea. It's an idea that is getting more and more traction, but it's still, to some degree, stuck. And we can think back to that CIW slide. We are not seeing the political changes that really reflect an understanding of the problems with income inequality, the need for appropriate poverty reduction strategies, et cetera. So there's still work to be done. It still takes time to explain this concept to most people. It's not on the tip of their tongues. So this is
You're standing.
Oh my goodness. Sorry, we'll try that one more time. I think it'll work again. Pardon me, I'm just gonna back up. So I'm gonna back away for a moment and talk to you about something that we're doing that we hope will help us to really bust out of the phantom zone for once and for all.
You're standing on the edge of a river. All of a sudden, a flailing, drowning child comes floating by. Without thinking, you dive in, grab the child, and swim to shore. Before you can recover, another child comes floating by. So you dive in and rescue her as well. Then another child drifts into sight, and another, and another. Eventually, hopefully, some wise person will ask, who keeps chucking these kids in the river? And they'll head upstream to find out. Every time we have to clean up an environmental disaster, every time a young person winds up in jail, every time people have to take medications to make up for the fact that they couldn't afford good food, we're suffering from the results of downstream thinking. Thinking upstream means making smarter decisions about what kind of country we want. What better goal could Canada have than creating the conditions for all people to enjoy true health and experience physical, mental, and social well-being? It's the best way to measure our success, and upstream thinking is the way we get there. Help us make the mainstream look upstream. Visit us at thinkupstream.net to find out more.
That came out just a couple of days ago, so I'm still kind of all butterflies every time I see it. I think it's great. Thanks. So really what Upstream is a response to the need for a movement that creates a new frame and that creates demand for ideas and actions that fit within that frame. Or maybe it's a recognition, and the more I have conversations about this, the more I think this is the case. It's a recognition that that movement already exists, that it's a movement that we're part of, but that hasn't been named, hasn't had the connection and direction to be able to really be successful. And I think there's an opportunity right now. And so that's why we've started Upstream, which is a new national, nonpartisan, new national nonpartisan organization really dedicated to moving us towards wiser decisions with that idea of a societal goal of health and well-being central to its mission. So how are we going to do that? Well, some of that is still very much in question and up to you, but we have some good ideas. Maybe I'll try not to belabor the water analogies too much, but things are still fluid. And but one of the places we start is in the tank. So this is the think tank side of this. This is the academic side of this, where we work with advocates, people who are recognizing issues on the ground, as well as academics, the people who are collecting the data, who are studying it, who understand the nature of our challenges, as well as understand what initiatives have been successful and what have failed, so that we can propose good actions. This is the place where we can put forward recommendations that are root-focused, they're evidence-based, and that they're forward-looking. That is not what was supposed to happen. There we go. Then the second part, and we had our little logo there. You see we've got the 3 boats. So boat number 1 is the tank. Boat number 2, storytelling, with this idea that we've got all these facts, and often we think, well, if we just had the information, people would change their minds, but it doesn't work that way. We need to add feelings to those facts. We need to work with different media. I was talking to Axel earlier about the great work that they've done at Access Alliance, involving slam poetry and video and dance and all kinds of other fantastic methods of sharing stories locally. So using a wide variety of methods to share our story, as well as a wide variety of hosts. So when you're talking to a group of people who work at community health centers, maybe a doc who works at a community health center is a good voice. I'm not sure, you can decide that. But probably if you're talking to the Chamber of Commerce, you shouldn't send me. You should send somebody who's already involved in the Chamber of Commerce but is engaged in these ideas. So finding a way to bring forward the stories of patients, the stories of people who are facing challenges with the determinants of health, but also finding a way to match those to voices that will be heard by the audiences that we want to speak to. And then the final section is really the development of a nimble network of people who are thinking along these lines, who want to see us moving more towards an understanding that social investment is not a cost, it's an investment, that if we think upstream, we'll be more successful. So finding a way to connect those people who are out there so that when issues arise, there's an ability to have a rapid response, but also so that there's a sustained commitment to change over time. So that, because it takes time for us to build a movement. It doesn't happen with a speech or two. It doesn't happen with just one campaign or two. You have to rinse, repeat, refine, rinse, repeat, refine. I suppose a stream doesn't change the political landscape overnight, but hopefully over time. So I want to tell you, just because it can be a little bit hard, that's still fairly abstract to really get your head around what Upstream might do, and I struggle with that at times as well. So I find it helpful to focus in on some of the specific campaigns. So here's a campaign that folks in Saskatoon will probably recognize. This happened last year as the Food Basket Challenge. Dr. Dosman, one of our docs at the community clinic, was among the local celebs that went on a 1-week experience of eating only what the food basket provided. They blogged about their experiences. There were videos of the coach of the Saskatoon Blades and how he was feeling weak-headed during practice, and other ways of just bringing up the story through a different voice of what it is like to live in poverty. So really engaging campaign, and I think very interesting, but it kind of ended abruptly. It brought up awareness, but it didn't really focus people towards an action. And we want to really be thinking when we put campaigns like this forward, what comes out of it? More than simply sharing the story, what's the action that emerges? So our first campaign is Upstream. We're working in partnership with the same group that put this together, Saskatoon Poverty Reduction Partnership, Food Bank, Saskatoon Health Region, and others, Anti-Poverty Coalition. And we're helping to provide some of the evidence to, pardon me, I need to tell you what we're actually doing before I tell you how it is. What we're doing this time around is cost of poverty. So getting people aware of how much poverty costs to the system, with the focus in mind, the action outcome in mind of moving the provincial government towards having a strategy for poverty reduction. So what we're doing as Upstream is helping to dig into the evidence of cost of poverty, helping to design the story. So we're using the story of a young child as they move through different experiences, like having to access healthcare or some struggles with education that are related to their poverty, and showing the cost that that incurs on the system for that one individual, as well as for the province as a whole when you think of how many people live in poverty. And then also helping to build the network, expand the reach of that story, so that when you get to the end and there's that action to demand the provincial government put into place a poverty reduction strategy, that the public momentum behind that is much greater. So that's the kind of way that we might work with organizations. And a final step that we want to make sure we involve all the time is learning properly from what worked and what didn't. So then going back and doing the analysis so that the Poverty Reduction Partnership can learn how to improve their next campaign, but also so that Upstream can further develop our own techniques around the kind of language we use, the methods of evidence gathering, the storytelling methods to see what works the best. Now, I realize I may be preaching to the choir somewhat here, and that's always a concern, but I think this is the best place for me to start, is preaching to the choir, because so often we actually have very common goals in mind, but we use different language to describe it, or we see ourselves as we're an environmental organization, not a health organization. We're a health organization, not a poverty advocacy organization, not seeing the common ground that's there. So I want to preach to the choir and talk about using the same hymn book to some degree. And that's my little joke about having a river run through it, that I think Upstream really does offer us one specific term that gets us into the conversation. It offers us a framework to examine the determinants of health and to talk to the public about political decisions around that. But it also gives us an organization that's working primarily on that, so that we can work in partnership with organizations of like goals and like values to further refine our messages, so that when we go out and say, we're going to do something about housing strategy in Hamilton, that the press is already primed for that, the audience is already primed for it, that we don't have to start way back here. We can start, I suppose, start further downstream in the argument, but because we've already sort of seeded the ground, prepared things enough that people are already thinking that way. Okay. So one of the things we thought would be fun to do before we get into the Poverty Reduction Partnership campaign, which isn't until the new year. We just launched our website yesterday, thinkupstream.net, and we've put on there a little box that people can share there or share on Facebook or Twitter the ways that they live upstream. And I'm going to point out that guy who's standing there, John Harriet, medical student. He put up his picture with a little line in front of it that says, I #liveupstream by engaging my classmates in political discussions. So what you've got is people coming forward and saying, here's how I already live upstream in my life, so that they're sharing their ideas with others, inspiring others, but also not giving the impression, Upstream's not giving the impression that we're coming in and saying, you haven't thought about this at all, and here's a brand new idea. But recognizing, no, this is something you already do in your own life. What we're wanting to do is really scale it up to how we look at politics overall, at how we make decisions collectively. And what I believe and what I hope we will see, is a reframe where we are doing the thought work that is, I suppose, upstream of the advocacy work that is upstream of the clinical work. And it's so hard to do this. It's so hard to step away from the front lines, from seeing patients, from being involved in the specific campaign you're in, to step back and look at the overall frame. But unless we do some of that reframing work, the social change we want can't happen, because it's like we have a society-wide mental block that's preventing us from making wiser decisions. So that's why I think this is so important, and it gives me hope. It gives me hope that we could do things differently, that we could actually, in the future, be telling stories differently. I mean, look back, think about Lisa. What if, instead of things rolling out the way they did, what if everything else had been the same in her family, but they hadn't been poor? What would we be dealing with? What if there had been childcare available when she was pregnant in high school so she could finish school? What if, rather than what appears to be an increasingly hollow apology for residential schools and a check, what if there'd been real help to help people heal and deal with the trauma that had come from that experience? What if there had been great early childhood development opportunities for her to be in care, to help supplement the struggles that her family was having in parenting? maybe instead of talking about going to her funeral, I'd be, I don't know, wrestling with her to keep smoking or something a little bit more benign like that. I know it's not benign, but how much I would like to be arguing with her about quitting smoking instead of having seen things turn out the way they did. So I put that in front of you, this idea of upstream, as something for you to consider and discuss. I believe there's a lot of appetite for these ideas, that this is an opportunity for us to really focus in on a common way of discussing it, and that this could really expand our ability to deal with what makes the biggest difference to our patients and clients. Thank you very much for your time. And I don't know if we're doing some questions, Scott, or?
Sure. Yes.
Yeah, I'm easy. Okay. Does anyone have any questions?
My name is Mary McNutt.
Hi.
We've talked on the phone, Ryan.
Yes,
Hi.
nice to see you.
And I work with Gary Machin and Adriana Tetley, all at the Association of Ontario Health Centres. And some of you heard about our work in the innovation stations, about our work with the Canadian Index of Wellbeing. And on Monday, September 30th, in Toronto, the association, along with CACHC, are going to be launching Community Health and Wellbeing Week. And the focus of that week is shift the conversation, community health and well-being. And we anticipate that that's going to be the theme, not just for this year's celebration, but for the whole, 3 to 5 years. And it's all about working upstream. I'm sitting in my hotel room this morning writing Adriana's speech for the launch. And it's upstream, upstream, upstream. It's all the same messaging. So I just wanted to say that I think you're right that there is this movement and that people are starting to get it. And our association, working with CACHC, are really going to be pushing it. So we need to talk.
Yes, we need to keep talking. And I'm glad we'd already started. And that's a great approach. And maybe somebody asked me yesterday, what's the long game for upstream? What do you really hope to achieve? And I think it's so wonderful that you're using that language, that we're moving to shifting the conversation. My long-term desire is I want to hear conservative politicians coming up and saying how they're addressing the determinants of health. I want us to start with us and create the demand among the public so that is the frame, so that people can't get up and talk seriously about planning for the future of our country without recognizing they have to address these issues. I want to hear upstream from every mouth, but it's wonderful to hear that it's starting to be so integrated into your work.
I am Gary Machin, and Mary just alluded to some of the work that we're doing. And one thing that just really occurred to me, I was involved in with the Ontario Medical Association around implementing and still the work around anti-tobacco work. And I think one of the things that I really learned through that work was the real power of their advocacy work. And I think a real key to the success was the simplicity of their strategy. And really, it was one word. It was denormalization. And everything was governed on that word. And I think what I really love about this concept of upstream, it's one word. And it's a word you can get your head around. And so, certainly as Mary indicated, I really look forward to the ongoing partnership. Thank you so much.
Hi, it's Adriana from AOHC, so sort of kind of dominate the AOHC theme here.
This is great.
But one of the things that I'd like to challenge the CHCs in the room is that even at AOHC and the community health centers in Ontario, we used to have a model of care with the word care in it. And in June, through the annual general membership meeting, we've adopted now the model of health and well-being and have expanded that the role and the responsibility of CHCs are beyond care. And not saying that they weren't doing it before, but we're trying to be more explicit in the language to encompass social determinants of health, community vitality, sense of belonging, as part of what the model of health and what the CHCs are all about. And I think that to CACHC or to the provincial associations, when we describe our own work, we need to get to the point where we describe it with health and well-being as part and an integral part of the work that we do, because we have so much work to do with the funders to acknowledge that health promoters who are doing more than healthy eating, active living, individual stuff, but that we're actually dealing with upstream part, community workers are core and fundamental part of what CHCs are doing and should be funded to do that. And right now, even what I'm learning from across the provinces, it's a struggle in Ontario, but it's even what I'm hearing across the provinces, it's a struggle elsewhere, that a lot of our community health centers are still heavily invested. It's not that it's not the work they have to do. They absolutely have to do the care part, but we need to balance it. And we need to start living the upstream stuff within our centers more than what we currently are doing, and challenging our funders that this is legitimate work. And so many times, I heard from a Lynn the other day, one of the regional health authorities in Ontario, one of them, not all of them, that said, we don't fund health, we only fund sickness. He didn't quite say sickness, but he says we fund care, we don't fund health. And if that's the decision maker's mentality, we still have a lot of work to do. So I think the challenge to CACHC and others, and we've been talking about, do we need to have a common framework for CHCs across the country that includes its health and well-being, and so be happy to engage in that conversation with what we're trying to do in Ontario to try and push the upstream language into what, you all talk about what everybody can do themselves. So what can CHCs do this? We heard yesterday we serve what percentage of the population? A high percent, I can't remember, 2 million people or something. So we have an opportunity here to do things differently even with those 3 million, but we're going to have to push the envelope ourselves as well.
Hi, Ryan. Michael Rackless, thank you so much for your presentation today and for all the work that you've done on this issue, helping to publicize it. I have a couple of comments and a recommendation, mainly to the room, actually. But first comment is that I think that you know this, but that really you're projecting values, but when talking about evidence-based policy, that it sort of assumes that everybody has common values. And I know you don't assume that, but that's clearly not the case. And that there's, the phrase, give me liberty or give me death, which is often used to oppose Obamacare. Of course, people who want that often get both. That they've got the freedom, but they don't have any health care. So, and yet that's fine with them. And I have tons of relatives of my wife's in the States who would argue for that to the death and might die from it. A lot of them don't have health care and don't have health insurance, and yet they argue against a universal plan. And then the other thing I'm going to mention is, just as we wouldn't expect a discussion about diabetes, clinical care, without having some physiology, endocrinology, that I don't think we should be talking about policy without some reference. And I want to just flag, if anybody's interested in the room, you can write me, but there's a wonderful article, Health Promotion International by Breton et al. In 2010, which goes through a bunch of health promotion literature that deals with policy and identifies that there's virtually no reference to any of the political science or policy literature. And I really feel that, again, you're venturing into the area of public policy. That's great. And most of the people who are into public policy actually have no background in public policy. Most of our politicians, right? I mean, but quite frankly, I think that we would be a lot more effective if we actually knew why things are the way they are. They're not stupid. Anything that's regular isn't stupid. So it's not as if people just didn't have this information, and that's why we've got today. And then finally, as a recommendation, we're talking, the organization you're talking about, the organizations that other people have talked about in this area, there was an organization created 100 years ago that was supposed to be taking this up. It's the Canadian Public Health Association. And I've mentioned this to other people at different times, but in fact, the Canadian Public Health Association has been gradually becoming quite a moribund organization. Anybody a member of the CPHA in the room? How many? Put up your hands. Like almost nobody, and yet, the people in this room live the values of the CPHA better than most people who are members of CPHA. CPHA has become an organization for administrators in public health, but it's what I refer to as a blocking organization, like a blocking drug, that because it's there in the environment, then it's very difficult to create another organization to do its mandate. So what my recommendation to people in this room is, and I've actually said to the CPHA, and I've said, you should be going to the health center. Have you ever been to an AOHC meeting? It rocks compared to your meetings. But I really feel that it's not like it's a hostile takeover. It would be a friendly takeover to engage the people who are involved in community health centers around the country and get into the CPHA, because as long as it exists, it's going to be, in fact, a barrier to trying to bring all the health people who are interested in social justice concerns around. So, but thank you again very much for your work. I think it's really making a difference, and thank you very much for speaking to our meeting.
Thanks. I'll just reply to not everything there, but a couple of pieces. One is that opening piece about the assuming common values, and I think that is a very good point. One of the things that I like about Canadian Doctors for Medicare is their tagline, evidence-based, values-driven. So they're recognizing that not all outcomes are equal. We have to know what it is we're trying to achieve. That's why I keep coming back, though, to that concept of health. And I recognize your example of the U.S., which I think may be somewhat of a different animal, but there's definitely some crossover. I think if we look at the values of Canadians, health still is one that cuts across political lines. So I think it really opens up a conversation with people who we would often think we shouldn't be even bothering talking to about politics because we so disagree. I think when we look at health outcomes, it really allows us to talk to, we were talking to Global News out here, and they were asking, how is this going to appeal to hard-bitten Saskatchewan farmers, i.e. my family? And I say, what we're talking about is better results for fewer resources. That still can appeal, but we need to talk about results in what is it we're trying to achieve. The second piece, health policy, public policy, moving beyond, moving into evidence, actually getting into the roots of causes of the social circumstances we see, absolutely. And I think that's a big part of the tank element of this, is really doing the outreach to create a network of thinkers that moves beyond the usual suspects and really digs into large areas, different areas of thought to inform what it is we're putting forward. As for the CPHA, I think that's a very fine recommendation that there be a friendly takeover. I think Upstream serves a somewhat different role. As soon as you say Canadian Public Health Association, you've turned off the minds of a great number of people who are about to listen to what you're about to say. It's just, it's inaccessible. I think that's one of the things that I like about Upstream. It's that one word that Gary mentioned. It's something that you can start with a story, you can start with something that people can understand on a personal and emotional level, and then move your way up to associations of public health, etc. Here and then Scott.
Hi Ryan, my name is Farrah, and I teach at UBC in the medical school in Vancouver. You're very welcome to come and talk to our medical students about doing this work, and I really hope you do. I hope you talk to all the medical schools in the country about the work that you're doing. It'll help those of us who work in public health in the medical schools move the agenda a lot further. Yeah. I just want to point to one thing. I'm sure it was a typo in your list of the social determinants of health. You had income status, and the way that we usually list it is income and social status. So we put income distribution as well as equality in society as the top two determinants of health. But I just want to point out how important it is for us to be moving really upstream in that area, particularly because the example that you spoke of was Lisa, who was an Indigenous woman. And so I think it is really important for us who work in progressive health movements to talk about racism against Indigenous peoples and land-based struggles of Indigenous peoples, and the fact that we unfortunately still live mainly on stolen land as Canadians, and to point to the important work that movements like I Don't Know More does, and to show how upstream they're really trying to take the country. And just to make a plug for the importance of social movements, social activism in trying to do that change. So it's really good to try to do that change from within institutions, but trying to do social activism is really important. And today we had a little meeting of our People's Health Movement to try to do just that. Yeah, thank you.
Excellent, thank you. Very good points. Yeah. Scott?
Yeah, I'm so encouraged that, you know, not only is Upstream conceptually strong and sound, but tactically, strategically progressive as well. I mean, the use of social media, the engagement around, as has already been said, around clear, consistent language, trying to harness all of our collective energies to be singing from a common hymn book, and I think Mary McNutt at AOHC has already coined that term, because AOHC has done tremendous work in that area to get us all singing, get Ontario singing from the same song sheet and whatnot. So all of that's fabulous, and you know, this clearly is going places, and I think we're all on board. I was happy that Michael referenced, you know, or challenged the premise that we're all working from common values, and you know, the fact that it's not just about knowledge exchange and doing that, but in fact we are in many senses, many of us diametrically opposed in our values and what for. So that, you know, I think if we then accept and whatever spiritual place we need to go to do that, accept that, you know, there are people who just do not share the values and don't give a rat's behind about equity, about sharing, about cooperation, about social well-being and so forth, then, you know, that obviously says that there's something we've got to do about power. We've got to be tactical and strategic about, you know, claiming the agenda and moving there, and there are all kinds of ways that we could do that. And you know, I think that's a really important question. But then moving back a little bit, I know I'm going all over the map here, but then moving back a little bit, and you know, I'm saying this to you. You'll know this obviously as a relatively new father as well. I'm, you know, a relatively new father as well. What, you know, having children, what having a child has done to me in terms of putting me in places and spaces where I find myself in rooms with people who I clearly and very quickly come to discover, you know, are diametrically opposed to me when it comes to that value set that we have in common, our children, you know, and that's a shared value. That's something that we see eye to eye around. That's a common starting point, you know? And from that, if, you know, I take a step back and say, you know, my gut reaction is to run the other way. I don't want to talk to you, you know, because all you want to do is talk about how fabulous Rob Ford is and that the war on the car is over in Toronto, you know? But I suppress my vomit instinct, and you know, I look at that family unit there, that dad or mom or parents with their child, and I say, we have our children in common. We've got to overcome that ideological opposition, and it's incumbent upon me to find some common ground to open up the conversation. A long way of asking the following question. What do you think about those strategic, those wedge areas for social justice and social change? Our children are some of those. What about those common grounds to actually convert the difficult to convert, those who don't fundamentally share that value set, but who we might win over? Because that's that's the really tough work. And have you had conversations around Upstream about, you know, how we do what those touchstones and entry points are, and if not, then fine. But I think that's something that we've all got to work on as well.
Mm-hmm. So very good point about how do you find those openings. You also made me feel guilty once again about having used my kid as a prop in the Upstream. In the river image there, but I think it's something that we have to think about in terms of, and you went all over the place, and I'm a little all over the place as well in thinking about this, because I don't think there's a universal wedge for us. I think there are multiple ways of getting at that, and that's why I think with Upstream what we hope to see is a longitudinal, consistent message but where there are waves in it, where we come out with, where we work with organizations on early childhood development and having campaigns around awareness of when we do this, kids have better outcomes. But where we also have, where we look at all the determinants of health and we go through them over time, where we work with Idle No More and talk about Indigenous rights and the needs there. So I think it's being, yes, smart about universal, what's the good big picture stuff that we can connect with lots of people with at once, and that's one of the reasons why I keep going back to health. Early childhood development seems to be sort of the sexiest social determinant for a lot of people, and I think obviously with good reason. The evidence is there and the heart is there, but we'll talk to different audiences about different things. We'll talk at different times about different things. It's maintaining the constant theme that I think is going to be the helpful sort of watchword, so that we don't get lost in chasing things down the wrong path. Does that? Yeah, there's much, as I said at the beginning, and I'll repeat this is an invitation more than an excuse. It's very fluid, and we're learning how to do this. The level of excitement among our group of, we've got a couple hundred volunteers signed up already, both folks just regular folks on the ground, as well as academics and other opinion leaders around the country. There's a lot of excitement about this, but it's still very much in formation, and you have an opportunity to help shape what this looks like, and I invite you to do so. And thank you once again for your time and for coming to Saskatoon and participating in this conference about the very important community health center movement. Thank you.
Well, we're about 2 minutes from the end, folks, so hang in. First of all, before I do a very, 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 very short wrap up, I'd like to thank again our sponsors for this meeting, Affinity Credit Union, the Rio Network, Saskatchewan Health Quality Council, Fairware.com, the AOHC. So thank you again for kicking in. And big personal thanks from me for inviting me to participate in this and allowing me to see and unsuccessfully try to steer your deliberations on the various topics. And just in closing the meeting, you've obviously got a massive number of issues to address, and I would only say a couple of things. One is you've got vocabulary matters, but if it matters too much, it's going to become a problem for you. So be passionate in your debate about it, but recognize that there are bigger fish to fry, I think is important. I think you have begun an inclusive kind of movement here, and I think the bigger your tent is, the better your tent is going to be. Thirdly, you've got to navigate a lot more ground than most people do in this area. You've got to be sticking to the knitting. I think the metaphor of rendering unto Caesar is going to be with you as long as Caesar is around, and never mind who Caesar is. But you also have the broader social agenda, largely talking a lot about the terrain that Ryan Meili just so eloquently gave an overview of. And navigating both of those worlds is hard. And I think it will require is multiple strategies to get there. We heard about the importance of being rigorous, measuring what matters, taking an ownership and a leadership role in the information system agenda in Canada is extraordinarily important. And I think you have a tremendous amount of talent, both here and people who are not here, that can help you to influence that agenda, and never underestimate the importance of that agenda. Because as you put it in your session title, Measuring What Matters, it is very easy to measure what doesn't matter, and it's also very easy not to measure what does matter. And you know, we've heard a constant theme in this meeting that you know a lot of things that you do very well, but they are difficult both to quantify and even to qualitatively describe. But just because they're difficult doesn't mean they shouldn't be done, and if you do them, you're going to have a much better chance of success. And finally, I think in building your coalitions and partnerships elsewhere, it struck me that in many of the conversations, you're fully aware that you have to talk to people who aren't immediately in the neighborhood of what you do, but whose support is going to be instrumental to your growth and thriving and expansion. So in a sense, you're going to need multiple vocabularies. As Ryan says, you're going to need to find a sweet spot with which to engage different communities, and it may not be the same sweet spot for all of them. And it doesn't have to be. While nobody universally shares values, often there is more common ground than we think if we only look for it. And if you can find common ground with uncommon partners, I think it's going to advance the cause hugely. So above all, I hope that you hang together more than you divide up. I think vigorous debate is essential. Unanimity is rare, and if you do have total consensus on something, it's probably not very interesting. But I hope you can harness your wonderful capacity for passionate debate to move your skill set forward and to put more rigor in what you're doing, but also recognize that sometimes you have to let it go a bit, you have to accommodate, and you've got to hang together because you've got bigger things to accomplish. I'm confident that you will. I'm also confident that when you meet in Ottawa in September of 2015 on the eve of the next federal election, that you will have a great and vigorous meeting with a lot more members. I am looking greatly forward to seeing how the nascent International Federation comes into play as it's the growing SDOH movement, Social Determinants of Health movement. If you look at where we are today in this conversation compared to where we were 10 years ago, I think it's actually come a long way, even though it has a long way to go. So I wish you all the best. Thanks again for coming to Saskatoon. I wish we could have arranged slightly better weather for you, but maybe the 2017 meeting you can have a return engagement. So